La próxima charla se titula Understanding Progressive Form of MS from Real World Evidence Data y está a cargo del Dr. Gavin Giovannoni. Gavin es profesor de neurología del Blizzard Institute Faculty of Medicine de la Universidad de Queen Mary de Londres, en Inglaterra. Siempre es un honor y un placer escuchar al Dr. Giovannoni. Adelante, profesor Giovannoni.
I would just like to thank you for inviting me to talk about understanding progressive forms of MS from real-world data. Just to say, I do have quite a large number of disclosures that may be relevant to this talk, as I'll be discussing certain disease-modifying therapies. So the objective really is to define progressive MS. I'll discuss something about the pathogenesis and bring in the concept of smoldering disease, about whether or not we can prevent or delay the onset of progressive MS. I will talk about some hypotheses that I think are supported by the evidence, both therapeutic lag and length dependency, and then I'll go forward with combination therapies and holistic management of MS. So defining progressive MS, prior to the modern era, we didn't actually have secondary and primary progressive disease. We used to put them together and call them chronic progressive disease. And you could go back to the 1980s and you would see that the cyclosporin and methotrexate trials were done on all comers, both primary and secondary progressive disease. But the concept of chronic progressive disease really only emerged in the literature in the 1960s that I could find. In other words, prior to this, MS was just considered to be one disease. And what then emerged is the definition of how you define multiple sclerosis. And probably the best working definition comes from the London group in Ontario, where they actually make the diagnosis retrospectively. And you'll see that the conversion to progressive MS, in other words, when it was defined, was at a very low disability score. Most people were diagnosed with having progressive disease with EDSS score of around 2 or 2.5. And the way they made this diagnosis is that they would actually get somebody in and query the diagnosis based on their history and put it in the notes. And then when these people came back later on and had worsening disability, they would then say retrospectively go back to the previous time point and make the diagnosis. So in other words, they would actually go back to the notes and say that person had secondary progressive disease when they first thought about it. So what they would wait for is a period of time, usually a year. Some people use 6 months, and then they would retrospectively go back and confirm secondary progressive disease. And this may explain why the diagnosis was made with such low disability scores. What we do know is that there's no difference in terms of the natural history of both primary and secondary progressive disease when you actually set the clock ticking from the time people are classified as having progressive MS. You can see that the Kaplan-Meier curves here in terms of worsening disability are identical. And this is quite interesting because the age of onset of primary progressive disease is about 10 years later than relapsing disease. And in the London, Ontario data set, it took about 10 years to transition from relapsing to secondary progressive disease, implying that these two diseases are very much the same. The only difference is primary progressive disease misses out on having the relapse phase of the disease. We don't see it clinically, probably because these people never had relapses or lesions in eloquent pathways. What has been happening though, and this is data from the Nordic countries, is that the proportion of patients with primary progressive disease has been falling. This could be two reasons. Either there's more patients been diagnosed with relapsing disease, or neurologists are more likely or more reluctant to label people as having primary progressive disease because of therapeutic decision-making. Now, once somebody has been labeled with PPMS, it's very difficult to treat their disease because only until very recently we had no treatments for primary progressive disease. So I think this dropping in the proportion of patients with PPMS is driven by two things: an increasing incidence of relapse onset disease and a reluctance by neurologists to make a diagnosis of primary progressive disease so they can treat their patients. And this is also borne out by the fact that the EDSS score that you diagnose people with secondary progressive disease is actually going up. And I say 4 in the 1990s, it's probably 6 or higher now. And the simple reason is as soon as you label somebody as having secondary progressive multiple sclerosis, it actually reduces their treatment options. So we're reluctant to do this. And I'm guilty of this myself. I would rather just keep the label in my notes at multiple sclerosis rather than putting secondary progressive there, simply because I don't want to disadvantage my patients. In other words, take away treatment options. And so I think this definition of progressive MS is a moving target, and it's mainly influenced by cultural factors like licensed therapies or the local guidelines rather than the biology of the disease. And this is also supported by the fact that prior to interferon beta, we didn't actually think about MS as being 3 or 4 diseases. We thought about it as being one disease. And the only reason why we have salami sliced up MS into different subtypes is because of the Orphan Drug Act in the United States. So back then, Chiron Burlex wanted to license interferon beta with one trial. And to do that, they had to define MS as being an orphan disease. In other words, less than 200,000 people with the disease. And the only way you could do that was by getting the FDA to agree that relapsing remitting disease is different to SPMS, different to PPMS. And when you actually go down into the biology of this disease, they're the same. There's no difference in the genetics, familial clustering, MRI, spinal fluid analysis, etc. There is no difference in my mind between primary progressive and relapse onset disease, and there is no difference between PPMS and SPMS. So I think this is just a cultural business classification, and I personally would like us to go back to MS being one disease so we can treat it as one disease. And this is why I've been running a campaign now for quite a few years on defining MS as one disease, not 2 or 3 diseases. Now, what about the pathogenesis? So now we're beginning to realize that even in relapse onset disease, what's underlying relapses is progression independent of relapses. And this is just looking at natalizumab, the observational program in Europe. And you can see that despite natalizumab rendering most patients relapse-free and MRI activity-free, you're still getting a significant number of patients getting worse, and that worsening is occurring independent of relapse activity. And we've called this PIRA. It's actually, PIRA now is identified even in patients with clinically isolated syndrome. Across the spectrum of MS, we're finding worsening being the dominant driver. Worsening without relapse has been the dominant driver of disability progression. And I've come to call this smoldering MS. I don't think PIRA sticks because PIRA kind of implies a relapsing disease. It's a metric that's driven in post-hoc analysis of clinical trials. And we're beginning to understand that underlying this worsening without relapses is this concept of smoldering MS. And there are lots of reasons why people with MS will smolder despite not having any ongoing relapses or MRI activity. Persistent demyelination, innate immune activation, or the hot microglial hypothesis, possibly intrathecal B and plasma cell activity with immunoglobulins driving worsening. There's obviously oxidative injury, mitochondrial damage, iron accumulation, which leads to energy deficits. Premature aging plays a role. We know that aging is inevitable, and people with multiple sclerosis have biological reasons why they age earlier. And there's also this possibility that viruses may be driving smoldering disease. So there are a lot of therapeutic targets that we should be addressing to treat what I would call smoldering MS, in other words, going beyond relapses and MRI activity. Can we prevent or delay the onset of progressive MS? I think almost certainly. If we go beyond our treatment target of simply targeting focal inflammatory events and start looking at end organ, in other words, how do we normalize brain volume loss, we will be able to treat MS. And the whole philosophy around this is basically how do we get into MS as early as possible with our effective therapies and building add-on treatments to target some of those processes that's driving smoldering MS. And we know that this is working. So this is just Swedish data from their registry showing that people diagnosed and onto therapy within a year of diagnosis do much, much better than people who have delayed access to treatment or delayed diagnosis. And this is just showing you the proportion of patients surviving, not getting to EDSS-4 is much higher if you go into treatment early. Similarly, this is open label data from Cambridge, just showing you that people treated with alemtuzumab, very few of them converted to becoming secondary progressive disease based on 2 consecutive disability worsening events. And this 5% is very low when you actually look at natural history studies. And this is actually a population of patients that had much more active disease. you would expect with about a 10-year follow-up, this figure to be close to 50%. So we're almost certainly having an impact on the conversion to secondary progressive disease with more effective DMTs. This is now data from MS Space, the international registry of patients, just showing you that people who are on high efficacy therapies, fingolimod, alemtuzumab, or natalizumab, have a much higher chance of reduced conversion to secondary progressive disease compared to patients treated with first-line injectable or platform therapies. This study includes GA, glutathione acetate, and interferon beta. I put forward the hypothesis that MS is a length-dependent axonopathy, and the reason why I did this was based on observations from clinical studies that when we use anti-inflammatory therapies, we have therapeutic lag. Now, when you're using MRI, you can see even with our most effective or the fastest acting disease-modifying therapy, natalizumab, you can see there's a delay of about 2 weeks before we start seeing an impact of MRI activity. So it doesn't work immediately. It takes weeks to work on MRI. And similarly, when you look at people with progressive disease, it may take many years to see a therapeutic effect. And this is data from the Spanish primary progressive trial of interferon beta in primary progressive disease. And you can see people were randomized to placebo interferon beta. And in the first 2 years, there is no difference. But when these people were brought back at year 7, people who had had interferon exposure for 2 years had much better outcomes on upper limb function, cognition, and brain volume loss. It just took a long time to see the treatment effect. And I call this therapeutic lag. It takes time, particularly when you're looking at lower limb function, to see an effect. And I put forward this hypothesis that it's probably length dependency. It's not a new hypothesis. Kurtzky had put this forward back in the 1960s, but only published this figure in 2015, showing, trying to illustrate that the corticospinal tract to the lower limbs is much longer than to the upper limb, and it accumulates more lesions simply by stochastic random effects, and you lose function in the lower limbs before the upper limbs. And I think we've seen this in clinical trials, and I like to think of this as the asynchronous progressive MS hypothesis. And in the systems with the longest axons, you begin to see progressive things like symptoms, bladder function, then motor. And it takes much longer to start seeing progressive pathology in pathways with more reserve. And we've seen this now when you go back and look at old trials, just looking at the low-dose methotrexate in progressive MS trial. The trials were negative in terms of EDSS and ambulation index, lower limb function. But when you look at the upper limb outcomes in that trial, 9-hole PEC test and the box and blocks, which is also an upper limb test, it was highly significant difference. Okay, so this drug was thrown out saying to be ineffective, but it was protecting upper limb function in people with more advanced disease. And they had more advanced disease. You can see 2/3 of them were EDSS 6 or 6.5. In other words, we're using a walking stick. And you try and modify lower limb function when most of the patients are using a walking stick it's just not going to work because they've lost so much reserve. It's very difficult to see a treatment effect. And this is why we saw an impact on upper limb function, more reserve capacity, but able to see a response to treatment and in the lower limbs. We saw the same thing in the interferon beta 1A, the Avanex trial in secondary progressive disease, negative on time 25-foot walk, positive on upper limb function. Similarly, in the secondary progressive natalizumab trial, when you looked at the primary outcome at year 2, the only thing that was positive was 9-hole PEC test, more reserve. Time 25-foot walk, EDSS dominated by lower limb function, negative. And what's interesting, when you brought these patients back in the open label extension at 3 years, you can see the multi-component outcome measure, the composite score was positive. So I think the ASCEND study is a positive study. It just was badly designed, and the primary outcome at 2 years didn't give us an answer. Ocrelizumab, we saw a treatment effect across all metrics simply because the patients in this study had more reserve. The average EDSS was 4.5 going in, so we saw a positive effect in lower limb function. But the treatment effect was almost double in the upper limb. And you can see the EDSS going into the oratoria was around 4.5. And what I'm trying to say is that if you have reserve, the majority of patients not needing walking sticks, you're likely to see a positive outcome. And so we've written this up as a hypothesis paper, but I think the evidence is overwhelmingly in favor of MS being a central length-dependent axonopathy. And we have to design our trials in progressive MS understanding this. And so if somebody has got more advanced disease, in other words, EDSS 6, 6.5 or higher, we should look at upper limb function rather than lower limb function as an outcome. So I think we've thrown the baby out with the bathwater, and that's one of the reasons why we are now doing the oratorio hand study. We're looking at ocrelizumab in primary progressive disease, but we're taking recruitment up to EDSS 8, and our primary outcome is hand function, not lower limb function. This trial is still recruiting. It's been delayed because of COVID, and now the war in Ukraine is not making much, not helping, because quite a lot of sites are in Ukraine. But we'll get to the end eventually. And we're also doing an investigator-led study in the UK where we're looking at oral cladribine in more advanced disease. Similar thing, we're taking people in wheelchairs up to EDSS 8.5, and the primary outcome is upper limb function using the 9-hole peg test. So it's important to protect upper limb function. You can see quality of life seriously deteriorates when people lose upper limb function, okay? And the cost of treating this also goes up. So there is a rationale to manage upper limb function and protect upper limb function in people with MS. I think we're going to have to move beyond anti-inflammatory therapies. So anti-inflammatory therapies clearly are important, but they act as a base. And on top of that, we really need to protect damaged axons, remyelinate them, and hopefully restore function with rehabilitation. And that's why I've got a really important emphasis on activity. We shouldn't expect people to regain function unless we rehab them. And this is one of the lessons we haven't learned. And if we're working in spinal cord injury or stroke, we know that recovery doesn't occur unless we rehab. At the same time as rehabilitation being added into our trials, we also need to target what I would call the non-MS targets. These are the things that affect brain health, things that improve outcomes in multiple sclerosis independent of inflammation. So how do we get our patients to stop smoking, drink moderately, exercise, improve their diets, improve their sleep, treat their comorbidities, etc. And so this is going to be, I think, a really important focus of MS management, particularly going forward to try and improve outcomes. So to conclude then, I hope I've convinced you that MS is one disease. The real MS is smoldering MS. I think the relapses on MRI activity are the immune system's response to what's causing the disease, and they're not the disease. I think we have now pretty good evidence that if we manage MS, particularly early and effectively, we will prevent or delay the onset of progressive MS. But we still need to manage expectations, particularly people with more advanced disease. What you've got to realize is disease-modifying therapies, particularly anti-inflammatory therapies, are a preventive therapy. They don't restore function. So if we allow patients to become too advanced, putting them on an effective DMT is not going to restore their function. It's going to hopefully prevent them or slow them from getting worse, and we need to explain that to patients. I think therapeutic lag and length dependency are real. This explains why it's so hard to modify more advanced disease, particularly people who are already using walking sticks. But we need to incorporate what we know about this into clinical trials so we can actually improve outcomes for people with more advanced disease. And I think going forward, we're going to have to do combination therapies. Okay, we have to go beyond what I call inflammatory disease activity, targeting other processes that we think are driving smoldering disease. And this is going to involve combination therapies, for example, using an anti-inflammatory as a base and then adding on other treatments to that. And I'd encourage you to manage MS holistically. There's more to multiple sclerosis than simply giving an anti-inflammatory therapy. We have to think about what other things we can do to improve outcomes. I'd like to finish there and take questions. Thank you very much.
Thank you very much, Professor. Really a very nice talk. I'd like to make two questions. The first one is related to what do you think about the studies, the real world studies and registries ongoing nowadays relate to the way they collect evidence in progressive phase. I mean, do you think that we are collecting the right evidence in terms of progressive forms? I mean, we collect
much evidence in terms of relapse, in terms of T2 or MRI lesions, but do you think we are collecting the right evidence, the right data for progressive forms of MS?
I think we are, but I think we need to collect more data because, you know, our worldview of MS is really based on MRI scanning and what we see clinically in terms of relapses and EDSS, expanded disability progression. And there's clearly more to MS than just physical disability. As you know, the EDSS scale is dominated by lower limb function. And so, you know, some of our registries just don't have enough, what I would call deep data in terms of upper limb function, cognition, vision, etc. So I would encourage people to, you know, try and collect data across multiple domains. But that's beginning to happen. But I also want to stress that we should thank the registries. Most of the data I spoke to you now has some of the most of the insights around what I've spoken to you have come from real world evidence. You know, either in after drugs have been licensed, collected by pharmaceutical companies or collected by academics. And so this whole concept of smoldering MS has come after these drugs have been licensed from real world evidence. So it's critical. I mean, real world evidence is really important in providing not only insights about the pathogenesis of the disease, but also about safety and pharmacovigilance. So yes, we've got to get registries going across the world. It takes time though, and nobody likes to spend extra time, but you know, you can see how valuable this data is when you do collect it and analyze it. It's really, really critical. And I think real world evidence has, you know, transformed our thinking about MS. And that even includes old real world evidence. So the London, Ontario natural history studies that were done by George Ebers and his friends in London, Ontario, have been instrumental in our thinking about progressive MS. So I'd encourage everybody, please collect data and do it in a standardized way and combine it, because we need big data. That's another thing, but we need big data. So,
yeah, yeah. Absolutely, absolutely. I agree, fully agree with you. And the other one is related with your practice, your personal practice in terms of the patient that is progressing, and you see a high EDSS and you don't see active lesions on the MRI, you don't see relapse. What do you do with the treatment? I mean, you're still using the treatment, you keep the DMD, for example, if you use a monoclonal antibodies, thinking in the way that the physiopathological aspect you already mentioned, or you decide to take off the treatment. How do you handle that situation?
No, I think they need the treatment because the treatment's doing what it says on the tin. You know, so these treatments have been licensed because they're very effective at stopping relapses and stopping MRI activity. So these people are what I call no evident inflammatory disease activity. The fact that we're not stopping the worsening or the smoldering MS is understandable because a lot of the processes are driven by old lesions, and those lesions smolder on, and there's lots of reasons why they're doing it. What we do, though, we give patients the benefit of the doubt. We may have to scan their cords to see they've got new lesions in their spinal cord. We offer lumbar punctures to measure neurofilament levels, and if they've got raised neurofilament levels or new lesions on the cord, we may escalate or switch their therapies. What we tend to say to them, this drug is working at stopping you getting new lesions. What it's not doing is repairing the old lesions. We recommend you go into clinical trials, and we've got a lot of trials running where we're testing what I call add-on strategies. So just to give you an example, we're doing a trial at the moment of a proteasome inhibitor that penetrates the CNS, and we're hoping it's going to go in and kill the plasma cells that are potentially driving some of these pathologies. We've got a big multi-arm trial starting in the UK called the Octopus trial. It'll be add-on. There's going to be 5 arms with a placebo arm, and we're hoping that some of those add-on therapies that are targeting these smoldering processes will actually add to the existing DMT. So I don't take away the DMT because we know what happens. You know, some of our patients, when you stop their DMTs, you give them a few months or years, they'll come back with recurrent inflammatory activity. So I think it's important to continue the treatments.
This is an important message to keep underestimated, that disease goes beyond relapse on focal lesions on the MRI, and we still have to keep the treatment. So thank you very much, Professor, for the lecture, and see you on your next presentation. Thank you.
Thank you.